Okay, so thanks, Dr. Cleve. So I thought when I was sort of thinking about a topic to choose to talk about around something that's, interesting and relevant, and so I thought, okay, well, let's have a look at imaging in prostate cancer. And I sort of thought, okay, well, it can't be that much to talk about. There's TRUST, there's MRI, there's CT scan, the kind of things we use every day should be relatively straightforward. So then I started to look into a bit more detail. I thought, well, hang on a second, hindsight is 2020, and actually there's a whole lot more information there than I initially anticipated. So what I propose to do is sort of go through some of the more historic things that have developed in the past and things that have been tried and not necessarily worked out, and then look at kind of evolving paradigms of where we might use modern imaging and how that might work for us, and try and work out which patients which imaging is for. So I'm not going to be able to go into a huge amount of detail on each sort of imaging technique, and I'm going to try and cover what I think is some of the important things that maybe the residents might need to know for exams, and certainly I needed to know for exams back home about the techniques involved, and then present some limited data of selected papers which I think are interesting or coming out. So I'm going to look at, as I said, some of the historical basis for this. We'll also look at imaging both in the diagnosis and for active surveillance, and what we should be aiming to use, and whether there's any differences in health constraints that might stop you using sort of things, and then look at sort of promising future directions and take it from there. So that comes up okay. So we've got to think, well, what's the goal of the imaging we're trying to look at? So, are we aiming to look at the primary disease? Are we aiming to look at what's in the prostate, how much the tumour size is, whether it's just one area, whether it's lots of different areas? Is there any extracapital extension and the seminal vesicle involvement, neurovascular bundle involvement if you're planning surgery, or is there any bladder involvement? So the question you've got to ask, is there one imaging that fits all that will give you the answer to all of that, as well as look for evidence of metastatic disease, or whether there's any lymph node involvement, bone metastases, other sites of metastases. And then increasingly importantly, will the imaging help you guide biopsies to an area that's going to be targeted in such a way that you're going to increase your yield of assessing clinically significant prostate cancer, but avoiding potentially clinically insignificant prostate cancer? And will the imaging give you an idea of that by looking at the functional and metabolic imaging? Now, unfortunately, no one imaging test is going to give you all those answers, because that's quite a lot of things to cover. So I thought, well, the first thing to start out is what are the current guidelines say? What should we be doing at the moment? So this sort of, I decided as a European, well, ex-European after the Brexit, I decided to sort of look at the North American guidelines and the EAU guidelines, and they sort of differ somewhat in the, I don't know if that works very well, but essentially in the European guidelines there's a lot more emphasis on the role of multiparametric MRI. So if you've got a patient that you've got a high clinical suspicion for prostate cancer, and they've had a biopsy, the recommendations, at least from the EAU guidelines, is that they should then go on to have a multiparametric MRI before any further biopsies. And also that multiparametric MRI should be used for local staging for intermediate risk and high risk prostate cancer. Whereas the NCCN guidelines sort of aren't as direct as saying, okay, this is what you should be doing. You should be getting an MRI, or you should be getting a CT. So there are some differences between the two different healthcare practices, and whether that's economically based or evidence based, we'll try and explore some of that. So, as I've said, I've promised to look at some of the historic tests, and the tests that we all know is TRUST biopsy, and that's commonly used. TRUST has been sort of tried to be developed in lots of different ways to try and increase the yield of prostate cancer detection, and we'll go through some of those. But essentially, the take-home message is that despite trying all these different techniques, TRUST alone, if you use that as an imaging technology to try and find a prostate cancer, will miss about 45% of cancers. So it was first reported in 1968, and you can see the kind of images they used to get back there, and there's a sort of chair set up with the man sitting on the chair and the probe going up in the rectum to to view the prostate. And what they're able to do now is with endorectal probes of between 6 and 10 megahertz is get a reasonable idea of the intraprostatic zonal anatomy. And one of the most important things it can do is help to give you a volume of the prostate, which can be useful more in benign disease to sort of work out, should the patient have a TURP potentially or anything else, and also give you an idea of surgical planning. Typically, the books say that prostate cancer is present as hypoechoic areas within the peripheral zone, but that's not always the case. So it's difficult to see because the slide here is half cut off, unfortunately, on my thing, but you can see here that this is an area of tumour and this is the central gland. I can't see what is out there, but 39% of prostate cancers are isoechoic, so you can't rely on that alone to detect your cancer, and 1% of prostate cancer is hyperechoic, so it's not that sensitive or specific for looking at prostate cancer. And as I said, there's been other techniques employed to try and improve that. So one of these is colour Doppler. Now, I sort of thought that, you might get asked in an exam, or we might certainly get asked, what is colour Doppler? And it basically assesses the flow of blood and I used to think that red meant arterial and blue meant venous, but that's not the case. So red is the blood flow goes towards the transducer, whereas blue it's going away from it. And we know that prostate cancer has increased vascularity as a result of neovascularization. So they thought by targeting areas of high vascularity, then Doppler can increase your yield of detecting significant prostate cancer. And in one series it found that the sensitivity of only 14.6%, but a specificity of 93.9%. So it's kind of helpful, but not that helpful. And in a separate study, what they actually found was that there was potentially a 10 times increased risk of recurrence post-prostatectomy with Doppler ultrasound. So it's not totally obsolete, but I don't think many places are using it as sort of standard practice to help guide biopsies, certainly with the advent of MRI. Power Doppler is again another kind of imaging using enhanced color Doppler, and it looks at the amplitude of the imaging and uses that as well as the velocity and directionality to sort of generate the image on the bottom screen. And again, you can see down here there's a potential area that shows high power Doppler. It's more sensitive to small amounts of low flow velocity, and so can be better than color Doppler. And it's been found to improve the sensitivity in detecting prostate cancer in one series from 87.9 to 92.4, and the specificity from 57.6 to 72. Now I double checked those figures because they're kind of the reverse of what color Doppler is. So I think when you look at that, you see that the baseline sensitivity and specificity for truss alone is quite variable between different studies. So, again, showing the difficulty with truss in detecting cancer. The other thing that's been used is contrast enhanced ultrasound. So as I said before, the neovascularization in prostate cancer results in hypervascularity because of angiogenesis. And if you inject microbubbles, that increases the density of those microbubbles in the microvascular areas, and it gives a sort of asymmetrical rapid or focal enhancement, which sort of again suggests tumour, and you can subtly see that in the picture here. The trouble with this is there's lots of different contrasts used, so it's difficult to interpret the literature on that basis, but it's likely it detects higher grade tumours. And again, it's in some studies shown the increased sensitivity from 38% to 65% versus unenhanced imaging, but hasn't really affected the specificity in these studies. So again, we're getting wildly variable baseline sensitivities and specificities for truss. And this again is showing a similar sort of thing. So this is the color Doppler with the power Doppler. And then on the bottom left here, we've got the contrast enhanced. And to an untrained eye, I've relied on the arrow to show me that's an area of what turned out to be clinically significant prostate cancer. There are some radiologists in the audience that might be able to tell us if that's not the case, but it was from Campbell, so it had to be true. So other things that have been used is elastography. And so elastography basically measures the stiffness of the tissue. So with the idea of it being that prostate cancer is generally stiffer than benign tissue. And so if you induce a mechanical vibration, you can get a sort of a map of what's called mechanical excitation, and that's then converted to an image. And you can see here again from Campbell's that on the left side there's an area that suggests, you know, higher resistance and more stiffness that was targeted in a biopsy and was found to have gleasonate prostate cancer. Now there's different ways of doing this. There's manual pressure, so the person doing the truss would put manual pressure and sort of get a differential to give you a picture, and then they can aim the biopsy gun towards that area. And that's been shown to have a sensitivity of between 72 and 92% and a specificity of 76%. The other way of generating the mechanical force is with acoustic radiation. So the ultrasound actually exerts the force on the tissue. So it can be difficult to get into the anterior zone, I'm told, but again, you can get a reasonable picture of elastography. And then there's shear wave elastography, which uses, again, acoustic radiation, and that creates a shear wave. And the velocity of that will determine whether, you know, give you your elastography picture. Again, reasonable sensitivity and specificity, but the difficulty is no one's been able to say, you know, that's the absolute cutoff that's going to suggest a higher incidence of cancer or not. And then histoscanning is I think, pretty much the final one I'm going to be talking about with respect to truss. It looks at the background scatter of ultrasound. So the ultrasound wave will hit the tissue and scatter back, and it records areas where there's you know, higher levels of backscatter that suggests possible prostate lesions. But a recent study of 105 patients said it wasn't actually that valuable in characterizing prostate cancer. So to sum up all of the different truss techniques, you know, despite all of those different adjuncts to just a sort of standard grayscale truss, up to 45% of cancers will be missed if you just perform a truss alone. So, you know, that's important to know that despite all these different things, we're still not getting that good results with it. So other things, just as a brief mention, as I said, I can't sort of go into everything in detail. There's 3D ultrasound, which has been shown can predict extracapsular extension and seminal vesicle involvement. One of the more interesting things that's sort of being looked at more now is potential using multi-parametric ultrasound, so combining all the different techniques, much as you might do in a multi-parametric MRI, to increase your overall detection rate from sort of 49 to 59%. And those patients that have had that, you tend to find a higher Gleason grade, so you're finding more clinically significant cancer. And I know that relatively recently Chedgy gave a talk on biopsy and prostate cancer, so I haven't covered truss and fusion biopsy, because otherwise we'd be here all week, I think. So, CT I mentioned in passing because that's one of the most commonly used staging investigations for prostate cancer. Certainly changed back home, so it used to be every patient got a CT, whereas these days most patients, with high-risk patients, would get an MRI. And basically it's used to assess for metastases. And you can look at lymphadenopathy, but again, we sort of aren't that good at saying whether a lymph node is positive for cancer or not, and tend to use size criteria. So again, looking at functional imaging, that may give us more information. We'll come on to talk about that a bit later. And I put up a case that Dr. White and I, Dr. Gleave, a case report of a guy with neuroendocrine prostate cancer, where CT was actually really useful in sort of monitoring his response to disease. He had this big liver lesion and a big soft tissue mass in the pelvis, and after 5 cycles of cisplatin, that kind of was melting away. So it can be used in certain circumstances, but it's not the panacea for imaging in prostate cancer. So then sort of the biggest topic, I think, the sort of the hot topic at the moment, and kind of spurred me to talk about this, was MRI. So I thought, you know, most urologists that I've come across don't really understand MRI that well, don't really understand PIRAS, and Dr. Goldenberg kindly sent out a recent pictorial review for the PIRADS 2, which is a really good place to start to sort of looking into this. But going a bit into the science of MRI, and again, I'm not a physicist or a radiologist, the idea is that the nuclei, the hydrogen atoms are sort of forced to line up in a certain way because the magnet puts them in plane together. So these protons normally spin randomly, but when the magnet of the MRI is turned on, they all line up. And then they sort of process in what's called a secondary spin, all at the same frequency. And then the radio frequency pulse is applied, and then the nuclei move out of alignment into the transverse plane. And this is what the MRI picks up. So T1 is the relaxation of that, and T2 is the decay. For prostate cancer, thank you, T1 will give you sort of fluid looks black and is good for assessing anatomy, whereas T2 fluid is white and is good for looking at pathology. So you can see here there's a lesion here that's in a T2 image. So it can give a lot more information than ultrasound. There are adjuncts to just sort of plain MRI that can help us determine, more likely is there a cancer or not. So I'm going to talk about diffusion, enhancement, and also potentially measurements of metabolites in spectroscopy. And it's also useful to assess lymph node status, again, primarily by size criteria, but we'll come on to talk about potentially conjoining PET with that later. So usually a multi-parametric MRI uses a T2 weighted imaging with added diffusion weighted and dynamic contrast enhanced as kind of the standard. And MR-Spectroscopy can also be used, but in the PIRADS reporting system this is optional. So diffusion weighted imaging looks at the way the Brownian motion of water molecules is, and so in areas of prostate cancer this is restricted because we talked about again the high cellular density, and so in a diffusion weighted image prostate cancer will appear hyper intense as there's restricted water diffusion, and so you get less signal loss. And then that's converted, as I understand it, into what's called the apparent diffusion coefficient. So this is why the two images look different. And in an ADC map, it's a hypo-intense lesion that will give an area of suspicion for prostate cancer. So those are seen here. Dynamic contrast enhanced imaging, I think the key here is dynamic. So T1 weighted images are used, and contrast is given, usually gadolinium, and it's given before, during and after the scan. And again, we've talked about the neovascularization in prostate cancer. So normally you would see early enhancement is a hallmark of dynamic contrast enhanced imaging, and it can be sort of assessed in three different ways. You can look at it qualitatively, so okay, this has got focal enhancement. Semi-qualitatively, so you can look at time signal intensity curves and determine whether there's potential cancer there, and look at the rates of wash in and wash out of the contrast. So all of those are put together in a PIRADS score, which I'll come on to talk about in a bit, which give you a potential risk for that lesion in the prostate seen on MRI for being malignant or not. Spectroscopy is not commonly used because it's I understand slightly tricky to do, but it looks at the cellular metabolite concentrations. So in benign prostate tissue, citrate levels are high, but relatively compared to cancer, these go down, whereas choline levels are higher in areas with high cellular density and cell membrane turnover, as well as those with phospholipid metabolism, so high in areas of potential prostate cancer. So it's the choline citrate ratio that aims to distinguish those that might be benign lesions from malignant lesions. And in practice, most MRI machines are sort of 1.5 Tesla, so they also look at creatinine because it's difficult to distinguish between the two. Again, it's labour intensive and not necessarily routinely used. And you can see here the double arrows point to peaks in choline and creatinine, whereas the lower arrows point to peaks in in citrate levels. So it suggests that in the areas where the spectroscopy has been performed, these areas are at higher risk of having prostate cancer, and in these patients that was confirmed by biopsy. So this is taken from that paper Dr. Goldenberg sent around, so it gives you a quick, I'm not going to talk about each specific point in the PIRADS, because again I think we'd be here for too long, but the take-home message is we look at diffusion weighted and the ADC in the peripheral zone, T2 weighted in the transition zone, and if there's any areas of sort of concern, then you add in dynamic contrast enhanced to sort of work out your final PIRADS score. And essentially, PIRADS 1 and 2, most people would ignore. PIRADS 4 and 5 are highly suggestive of significant prostate cancer, and PIRADS 3 is somewhere in between. So I don't think anyone has sort of, there's not a huge amount of data to say, okay, you can ignore all PIRADS 3, and certainly the practice here is if there's a PIRADS 3, then they're usually amenable to a fusion biopsy given a certain clinical scenario. So as I said, one of the things that sparked my interest in this, and again I'm slightly biased because it's a UK trial, was the PROMIS trial. Now it's unfortunately not been fully published, but it was presented at ASCO, and it looked at multiparametric MRI as a triage test prior to biopsy. So the patients with a high clinical suspicion of prostate cancer who would normally go on to book a trust for had a upfront multiparametric MRI. And then they went on to have a trust biopsy, but before the trust biopsy they would have a transperineal template biopsy where you take cores of the prostate through the perineum at 5mm intervals. One of the problems with all the imaging studies is you can't compare the image to tissue in a lot of cases, because if you're not taking the tissue you can't see whether there is actually what your image is trying to detect is going to show what you want it to detect, if that makes sense. So rather than using prostatectomy as the sort of correlate, they've looked at transperineal biopsies. And so they were looking for what they defined as clinically significant cancer of least than 4+3 or above. And you can argue whether that's the right thing to look at or not. But they randomized 576 men. 40% of them had a positive transperineal biopsy. And they found that the multiparametric MRI gave a sensitivity of 93%, but a specificity of only 41%, but performed much better than TRUS alone. So and the difficulty is we haven't seen all the data, but they then wanted to say that, by using multiparametric MRI, you could potentially avoid biopsy based on their data in 158 men, but you would miss 14 patients that had potentially clinically significant cancer. And one of the limitations, or I guess it was more of a real-world practice, is that rather than every patient that's had an MRI having a sort of targeted fusion biopsy, they all just sort of had a standard trust biopsy. So they went on to argue that if they were to have a fusion biopsy, then the likelihood is that they would miss only they would detect another 17 patients, so they would only be missing relatively few patients with clinically significant prostate cancer and avoiding all those unnecessary biopsies. But, as I said, we haven't seen the full data, so I think, that's a paper that I'm certainly waiting to see the full results of. And obviously, healthcare constraints mean that not every patient can get an MRI and a fusion biopsy, and certainly not every patient can get a template biopsy. So, it would be interesting if they repeated the study to see what the results were with a targeted biopsy as well. And then another meta-analysis of multiparametric MRI with guided biopsies again shown improved sensitivity and specificity. That bit's come off my slides. Okay. Then I thought, okay, well, we can't rely on just singly unpublished data. So there was another trial that looked at MRI up front. It's published in Urologic Oncology. And basically, the aim was to assess detection of clinically significant prostate cancer using multiparametric MRI and targeted biopsy versus TRUS. So they had quite a significant cohort, 570 patients in each group. Group A had a TRUS only, and Group B had a multiparametric MRI with a truss biopsy and a targeted biopsy. So 215 patients out of the 570 in Group A had prostate cancer diagnosed straight away. And then the remainder went on to have a multiparametric MRI. And 208 of those, the MRI said there's a cancer there, and then further biopsies were positive in 186 patients. And if you compare that to 440 patients in Group B who had a positive MRI, 417 of them had a cancer at their first biopsy. So you can see that MRI helps potentially detect more prostate cancer. And I don't know if this projects very well, but essentially goes on to show that patients that had a negative biopsy would then go on to have a saturation biopsy to try and sort of, as a correlate of, having a prostatectomy to see did they have cancer or not. So, again, there's limitations on that front, and they also use Gleason 6 as their baseline of saying this is clinically significant cancer. So there is some flaws potentially in this study. But of those patients who went on to have a prostatectomy, they showed that the MRI, when looking back at the data, had a sensitivity of 86% and a specificity of 94%. So showing that there is potentially more of a role for MRI than is currently used. So again, I can't talk about all the roles for MRI, but I briefly talked that it can be useful for staging and pre-op planning. And it can predict, has a high negative predictive value for extracapsular extension from anywhere to 57 and 97%, so it can help stage your patients more accurately, and you can therefore offer them the best treatment. You can also assess the lymph nodes, and I think MRI is certainly better than CT scans, so again pushing the MRI boat a bit further. And in one study it showed that based on the results of the multiparametric MRI, surgeons potentially changed their nerve spare in up to 27% of patients without affecting pathological outcomes, so still with negative margins. So it can be useful to help guide how close you want to go on the prostate. And then active surveillance, certain protocols have shown that you can decrease your biopsy rate by about 68% if you use multiparametric MRI in your active surveillance cohorts, and that if you compare systematic biopsies versus fusion biopsies, you need to do 2.9 fusion biopsies or 3 fusion biopsies compared to 9 systematic biopsies to detect one case of Gleason progression. So showing again that you can sort of limit the patient's exposure to biopsy. I'm not sure. I'd have to double check the exact. I've looked at so many different papers, it's difficult to know exactly what I can look that up for you. And again, not talked about, even the differences between fusion techniques and whether MRI can look for local recurrence. So there's some evidence that spectroscopy can look for local recurrence and for follow-up after radiotherapy. And again, MRI can be used for a whole body for looking for bony metastases. So in the interest of time, I'm not going to spend a huge amount of time talking about bone scans. It's kind of been around for quite a long time. Technetium-99 labeled methylene bisphosphonate, and it's generally thought to underestimate the burden of metastatic disease with lots of high false positive rates. So you've probably all seen the report that says could be degenerative, could be inflammation. So generally it's a test we routinely use, but it's not always that useful, if that makes any sense. So I thought the next part of the talk is to sort of briefly talk about PET. So unlike a bone scan, which uses gamma emission, this uses positron emission radionuclides, and it relies on specific combination of radiopharmaceuticals that will sort of target a specific cell that has specific characteristics. And these days uses often multimodal imaging, so you combine a PET with a CT or an MRI to give you sort of both functional and anatomical information. the difficulties with PET is, depends on what radio tracer you're using, because sometimes they need to be made on site, so it can limit its sort of widespread use, and it's relatively labour intensive compared to a CT. But essentially, once the radio tracer is injected, that will then go to the tissue of interest, and as it decays, it emits these positrons, which are detected on the ring detectors and then correlated with the anatomical images can give you an idea of potential activity. So probably the most commonly used PET tracer in oncology as a whole, but not necessarily urology, is FDG PET, and that looks at areas of high glucose metabolism compared to benign disease. So certain cancers it's very useful for, but prostate cancer is less metabolically active than other cancers, and so is not as FDG PET is not as useful in prostate, and has now largely been superseded by other radio tracers, which we'll come on to talk about. But nevertheless, this shows an FDG PET of a patient that had an obvious bony lesion on his PET. Sodium fluoride PET, again, this is sort of trying to potentially give us more detailed information compared to a bone scan. It looks at areas of high bone turnover, and so the fluoride is rapidly taken up by bone, and areas of metastases generally have more rapid bone turnover. And there was a recent study that, and I haven't gone into huge amounts of detail of this, but the results of a PET may change what a clinician does. So that the clinician was asked, what would you do with the result of this bone scan with this patient? And they said this would be the treatment plan. Then they have the sodium fluoride PET and get a different result, and they said that the result of that PET would change their treatment decision making in 77% of cases. Currently there's a sodium fluoride PET study ongoing here, and interestingly saw a patient yesterday who, to all intents and purposes, had sort of perfect candidate for, well, not perfect candidate for, but would be a candidate for active surveillance. Had reasonably high volume Gleason 6 disease and a PSA of 12. He was like, hey, I want to go away and think about it. He had a bone scan which showed a subtle abnormality potentially in the T12, and then says, okay, well, let's enroll you in this trial and see if that sheds any more light. So he had another bone scan a month later, which again, the bone scan said, oh, we can't really call anything here. It doesn't really look like metastases. And then he had a sodium fluoride PET, which showed he had a frontal skull lesion, an iliac lesion, and a definite positive T12 lesion. So it was certainly more accurate in sort of assessing for metastatic disease. The issue then comes, yeah, so it's really unexpected. The issue then comes with you kind of, the patient, we weren't expecting it, and you're kind of thinking, okay, well, now we've got this test that's shown something, what do we do with it? So I would say that one of the things that goes through your mind when you're looking at all these studies is the outcomes of all the studies we look at are based on historic, imaging. And, we've seen recently from the PROTECT study that at 10 years, apparently doesn't make a difference what you do. So, some of these imaging techniques, are going to change the population we potentially treat, and it's going to be a long time before we see the effects of that potentially.
I didn't know that's a true positive.
But that's the other thing, you don't. But I think so. The bone scan, you have to kind of err on the side that it should be more accurate. But again, you don't know.
Even more specific, you lose sensitivity in general as you try to increase specificity. So, you lose specificity as you try to increase sensitivity.
Yeah.
So this increases sensitivity. So it does increase your false positive.
Yeah. But I think given that the bone scan, he'd had 2 bone scans, so this guy in particular, he'd had 2 bone scans. The first one was, we would call this, not suspicious, and the second one, well, it's starting to look a bit more suspicious. So I think, it's difficult. These are the questions that... Yeah.
Yeah. Well,
yeah.
He's got 9 in there somewhere. Maybe an anterior lesion.
But I think you need to confirm that with MRI or CT. I think that's, or this is
Or radical prostate.
Anyway, before we get sidetracked. It just sort of goes to show that, you know, some of these imaging techniques that are purported to give us more information actually give us more questions than answers often. Again, one of the more interesting, more recent developments in PET scanning is PSMA PET. Now, PSMA is a cell surface enzyme that's expressed on prostatic epithelial cells, which is highly upregulated in prostate cancer and usually linked to more aggressive behaviour. It's also linked to AR independence, so there's a lot of interest in this in patients with CRPC, and it's mainly been developed in Heidelberg in Germany, as well as some centres in Australia. And this particular PSMA radio tracer has a strong binding affinity to this membrane antigen. And again, you can see that it shows up quite nicely in some of these images. Unfortunately, I'm only getting half the picture, so so I can't read exactly what it says. So one of the studies, there's been a recent systematic review and it's looked at 16 articles with nearly 1,400 or 1,300 patients that have had PSMA PET. And it's shown that PSMA PET is positive in 40% of patients that they've looked at for primary staging, and 76% of patients where they looked at biochemical recurrence. And that the pre-PSA, pre-PET PSA is predictive. So as your PSA goes up, then the chance of your PSMA PET scan being positive also goes up. And across all these studies, they found a sensitivity and specificity of 86%. And the conclusion was that it compares favourably to choline PET. So I think we'll see increasing use of PSMA PET, and I think there's a trial about to open at the Cancer Agency. The exact enrolment details, I'm not 100% sure. But I kind of put this slide up just as a sort of, these are all the different PET tracers that have been used or potentially will be used in prostate cancer. I've heard of a few, but I certainly haven't heard of most of them. So it just goes to show that there's a lot of interest in this and in helping us to characterize our patients better. And this again was a slide just sort of coming into a summary slide here, looking at the different imaging techniques. And this is in prostate cancer, prostatic diseases, looking at staging accuracy for high-risk prostate cancer. I highlighted the area that sort of basically says that we shouldn't really be doing CT anymore because there's a lot better tests out there now that are more specific and more sensitive. So it'd be interesting to see the impact of that going forward. And then the final sort of summary slide to look at the different imaging techniques. So, you know, a lot of them look at initial detection, a lot of them look at diagnosis, and, you know, some are relevant for active surveillance. There are advantages and disadvantages for them all, but I think urologists need to have a working understanding of all of the different techniques so that we can choose the test we want to get the answer to the question we're looking for. And I've mentioned a couple of the trials going on at the moment locally. There's also an MRI trial that Jimmy's helping to run, as I understand, so looking at patients are going to have prostatectomy, they have a preoperative MRI, and then comparing the MRI results to the whole mount of the prostate. So that would be a really interesting trial to see you know, how sensitive and specific the MRI is.
These patients are diagnosed in biopsy.
Yeah, yeah. So I hope that I've kind of done some justice to some of the imaging techniques out there. I think before I started this, I was rather naively thought I'd be able to cover a lot more than I potentially have. So I've tried not to get too bogged down in technical or sort of too many papers. I think there's a lot of information out there, and it's clear that no one test is going to give you all the answers you want. So as I say, you have to choose the test that you want to answer the question you're asking. I think we're going to see increasing use of MRI and PET in the future. And as I said before, one of the difficulties is particularly, you know, the patient I talked about, how can you compare, you know, there's no tissue from a PET scan. So, you know, it's difficult to get a frontal bone biopsy to compare the sodium fluoride PET to the, you know, what you're seeing in the patient. So these are some of the challenges that I think we're faced with when we're sort of assessing this. And also this will change the cohort of patients we're treating. So, you know, we can't sit there and say we've had this test, this, you know, this is going to be the result. And I'll just leave you with one final thought to try and lighten the mood a little bit.
What's the thought?
Can you read that or not? No. So it says, so this is the doctor says, my friend, the year, this is a bit old, the year is 2011. I have a machine that can look through your skin and see your bones. I have a machine that can keep you alive, even if your brain and heart don't work. I even have a machine that can look at the drop of your spit and tell me who your parents are. But right now, I need to roughly gauge the approximate size of your prostate. So I'm going to stick my finger in your butthole and wiggle it around a bit. So the patient says, seems unnecessarily archaic. And he says, and yet here we are.
Thanks.